Did you know that 1 in 3 older adults experiences confusion during hospitalization? This is called delirium, and it makes hospitalization much, much harder. Fortunately, in many cases, it can be prevented. So in this episode, I'll tell you what's most important to know and do when it comes to hospital delirium. Hello, everyone. I'm Dr. Leslie Kernisan, board-certified geriatrician and founder of the website betterhealthwhileaging.net. And this is the Better Health While Aging video podcast, where we discuss common health problems that affect people over age 60 and the best ways to prevent and manage those problems. In today's episode, I'm going to cover a very important aging health issue for you to know about and understand, and that is why so many older adults experience confusion during hospitalization. Now, this is called delirium, and for a very long time in the medical field, people didn't really take it seriously. Everybody who worked in hospitals knew that lots of older adults would get confused during hospitalization, but nobody actually did anything about it. Families were just left to be shocked and confused when it happened. But in the 1980s, a young geriatrician named Dr. Sharon Inoue looked around and thought, what is this? How can we just assume this is okay for older adults? She felt this was an important condition to better understand. She noticed it often seemed very harmful to older adults. And so she basically on her own launched the study of delirium as an important clinical syndrome. And so today we know lots about it, and it is in part because of her really groundbreaking work to not wave this off as just something that happens to older adults, but to treat it as something important. So today it's a major focus for geriatricians, but also for hospitals because it does affect the hospital experience and success with hospital discharge. So many hospitals, but not all, today do have programs to prevent and detect delirium and to provide better care when it's there. So if you're an older adult, chances are high that at some point you will either experience delirium while you're hospitalized or you'll see an older person you care about experience delirium. So I think it's really important for you to know at least the basics about this condition because it is possible to reduce the chances of it happening. And also, if it does happen, I want you to know how it should be managed so that you can advocate effectively and follow along. So specifically, in this episode, I'm going to cover what is delirium, why it matters, what causes it. I'm also going to talk about how to prevent it, and then I'll talk about how to diagnose it, how it should be treated, and what to do if you're concerned. So we'll get started with that, but really quickly before I get into it, very quick request. If you're here, you find this helpful. If you haven't yet subscribed, could you please subscribe? It would mean a lot to me. It does help more people find the channel when you subscribe, and it helps support the work I'm doing. Another option, if you appreciate my making these videos, and especially if you appreciate that I'm a real live doctor and not an AI-generated source of senior health information, you can become a member of this Better Health While Aging YouTube channel. And to learn more about that, just click the join button under this video. Okay, onward with delirium. So what is delirium? So technically, it is a clinical syndrome involving acute changes in consciousness, especially altered cognition, so changes in the way the person is thinking, and in attention, changes in their ability to focus and pay attention. So what this looks like in practical terms is that it generally causes new confusion, or for somebody who already maybe has some ongoing confusion, if they're an older person with Alzheimer's or a form of dementia, they might have worse than usual confusion. It also causes increased difficulty paying attention, and the symptoms are generally going to fluctuate so that sometimes the person seems like their normal self, and other times they're very confused or very spaced out and out of it. It can cause a lot of agitation. It can cause people to be very restless, sometimes even raving. It can cause people to hallucinate and see things that aren't there. It can cause them to have delusions and believe things that are not true. And all of this can be very stressful for family to observe and also distressing for the person who is actually delirious. Families are often not familiar with the term delirium, and so they may mistake this for sudden onset Alzheimer's or dementia. I've had many people tell me this, that an older person, was fine and then suddenly developed Alzheimer's while in the hospital. And if it's a sudden onset of confusion or a change like this, we would really assume that it is delirium, not new onset Alzheimer's. Now, it's true that some people are actually slipping cognitively. Nobody really realized. And they can experience delirium in the hospital and later have difficulty recovering. But this doesn't mean the Alzheimer's started, right in the hospital. It was usually pre-existing, just not really noticed before then. So why does delirium happen? It's generally triggered by illness or some type of physical stressor. So I think of it as the brain kind of going haywire when there's a lot of medical illness or physical stress on the body, and the brain kind of can't hold it together anymore and tips into one, inattention, two, a lot of confusion at times. So what are examples of these illnesses or physical stressors that can cause this? So a really common one is surgery. Surgery is a big stress on the body, especially if it's an open surgery, the body being cut open. And also people are often put under general anesthesia, and that's a stress on the body and the brain as well. So quite common for us to see delirium after surgery. Hospitalization in general often triggers delirium, and this is often thought to be a combination of the person being sick enough to be hospitalized and also the fact that the hospital is often a very stressful environment for older adults. And then we also see a lot of delirium when people are in the intensive care unit, the ICU. This is again because they tend to be very sick if they are in the ICU, and also that's a stressful environment for the body, even though it does allow us to provide really life-saving forms of medical care. Now, it's important to know when it comes to hospital delirium that it comes in two main forms. The one that everybody often thinks of is the really what we call hyperactive delirium, where people are very confused, agitated, restless, kind of making a fuss, right? But it's important to know that often delirium presents as hypoactive, and the person is actually quite quiet and spaced out. It's very easy to miss delirium. We often assume they're just tired, they've been sick. But if you try to interact with them and realize that they really, can't pay attention the way they usually do, or when you do talk to them, they're kind of mumbling and confused, that would be delirium. And we don't want to miss that. And then delirium, I am talking about it in the hospital. That's where people often see it. That's an environment that's especially likely to trigger it. But it's important to know that delirium does happen when people are not hospitalized. And for some people, it can even be triggered by, seemingly, minor things, such as certain medications, certain outpatient infections, or more minor medical stressors. And this is true, especially if somebody already has a vulnerable brain. So if they've already started to develop brain changes, they may or may not have been diagnosed with something like Alzheimer's or dementia. Basically, the more vulnerable the brain, the easier it is to be tipped into delirium, and the less of a medical stressor it takes. So why does delirium matter? I mean, for a long time, delirium was just taken as one of those things that happens when older adults are hospitalized fairly often. So why do we care so much about it today? Well, first of all, it is extremely common. It affects an estimated 1 in 3 older adults in hospitals, and that rate goes up as people get older and older in age. It's distressing for older adults and families. It's also unsafe. People get hurt actually when they're delirious, as you can imagine. If they're kind of confused, they may get out of bed before they have the right support and fall. They may be pulling out their IV or other forms of medical equipment. It also matters because it can improve over a few days, but for some older adults, it takes weeks or months. So this is a significant situation, right, that is going to affect the hospital discharge, the plan of care right after hospitalization, and the recovery. Because when there's delirium, it does make that hospital discharge and recovery more challenging. And then it matters because a lot of research has shown that it is associated with acceleration of cognitive decline. Now, I don't want you to panic. If you or somebody you know has had delirium, that doesn't mean you're done for cognitively afterwards. But we do know that especially people who are already experiencing some decline before, if they experience an episode of hospital delirium, many of them will actually experience an acceleration in their decline afterwards. It does seem to create a big stress on the brain that can really cause sort of lasting effects for some people. Lastly, I want you to know about delirium because historically it has been really easily missed by hospital staff. So again, if people are having the quiet form of delirium, they're just quiet, nobody's paying attention. Or hospital staff may assume that an older person who's confused, that this is their normal state of mind. This is to a certain extent a form of ageism, actually, but it is something that is fairly common. Lastly, delirium matters because we have learned through the work of Dr. Inoue and others that delirium actually is preventable. Not all cases can be prevented, but when hospitals take certain steps, when hospitals and patients are proactive, about providing a better environment around the hospitalization and better conditions, we avoid a lot of delirium. This has been studied in clinical trials. And I'm going to talk more about how delirium gets prevented later in this episode. But we can only make an effort to try to prevent it if we know it's a thing and if we know it's worth paying attention to and thinking about. So what does cause hospital delirium? So generally, I think of delirium as due to two kind of types of issues. One is baseline risk factors that make older adults more vulnerable. And the next is precipitating triggers. So what do I mean by baseline risk factors? So first and foremost is advancing age. As people get older, their risk of experiencing delirium during a hospitalization gets higher. This is partly that as we get older, we become physically less resilient. And also, I think reflects the fact as people get older, especially when they get into their 80s and 90s, it's more and more likely that they might have some underlying brain changes that have been happening over time, maybe related to vascular changes in their brain, maybe related to underlying neurodegeneration. We do know now that Alzheimer's and other forms of neurodegeneration have often started in the brain 20 years before symptoms are apparent. So as people get older, there's a higher risk of all that happening. And then, yes, if there is an actual underlying brain disease, such as Alzheimer's, Parkinson's, Lewy body, so forth, that creates a risk factor for delirium in of itself. We know that the risk of delirium when in the hospital or when sick is much higher when people have a diagnosis of Alzheimer's or another form of dementia. And then some other serious medical conditions are also associated with a higher risk of delirium, such as advanced cancer. And then there are the precipitating triggers. So these are the things that I think of that kind of tend to tip people or stress them and tip them into delirium. So I'm going to go through them. And a major one when people are in the hospital is infection or the other forms of illnesses that are causing hospitalization. If people are sick, if they have abnormal blood electrolyte levels, abnormal kidney function, or just a lot of infection going on, that can definitely make them delirious. Another thing for us to consider sometimes is the possibility of alcohol or drug withdrawal. There are some older adults where it may not be known to hospital staff. Sometimes it's not even known to family that they have been drinking alcohol chronically at a level to provoke withdrawal if they don't drink for a few days in the hospital. So if somebody becomes delirious in the hospital, we want to consider that possibility as well. Other triggers, general anesthesia. Definitely a potential trigger for delirium. Surgery, again, it's a big stress on the body. And then there are things that are just related to the stress of the hospital environment. Historically, hospitals have been very stressful places for the aging body. It's fairly common for people to be woken up at night for blood draws or blood pressure checks, or just because there's a lot of noise. Older adults may not have their hearing aids or glasses, which contributes to being disoriented. They may end up dehydrated. Depending on the setup of the hospital room, there may not be a window with access to natural light to help them regulate their day-night cycle. And all of these are thought to contribute to the stress on the body that can provoke delirium. And then there's medications. So especially medications that affect brain function, such as anticholinergics and other psychoactives. So if you have been following this channel, you have heard me talk about anticholinergics. They're medications that affect the levels of acetylcholine or the function of acetylcholine in the brain. That's an important neurotransmitter that is involved in lots of cognitive processes. And lots of commonly used medications are anticholinergic, including something like diphenhydramine, brand name Benadryl, which when I was training as a medical resident would be given to hospitalized patients to help them sleep because often they couldn't sleep at night because of all the noise and stuff going on in the hospital. And we now know that using those medications is associated with developing delirium. Again, we want to be thinking, could there be electrolyte imbalances in the blood, kidney or liver dysfunction? Another potential trigger is physical restraints and catheters. These have definitely been associated with increased risks of delirium, either tying people to the bed rails, which used to be done so they couldn't pull out their IVs. A urinary catheter can also be experienced as a form of restraint for a vulnerable older adult. And then there's the possibility of acquiring a new infection in the hospital. So having an infection that is not the thing that the person came in with, but that they might have developed. Again, if they had a urinary catheter in for a few days, they could get a UTI from that. And what you should know is that when it comes to most older adults, usually we can identify several triggers, not just one smoking gun. So we want to be mindful that often delirium is thought to be multifactorial with like multiple triggers, especially in somebody who has underlying risk factors, tipping them into this confusion and inattention, which is the hallmark of delirium. Now, delirium especially affects older adults. However, I want to point out that younger adults can and do become delirious. Anybody, if they are sick enough, can start raving or hallucinating due to the effect that the state of illness can have on the brain. However, the younger you are, the healthier your brain, the more overall resilient you are, the sicker you need to be to reach the threshold of delirium. So let me now say a few words about preventing hospital delirium. I am going to talk about how it gets diagnosed, how it gets treated. It's very important for us to know about that since we see a lot of delirium in the hospital and outside. And I will tell you right now that the best approach to delirium is to be proactive and try to prevent it in the first place. And that's actually where we have really good data. So this has been studied, and it's been found that when patients and hospitals especially take proactive steps to minimize the triggers and the stresses of hospitalization, we see fewer older adults becoming delirious. And so it's been estimated that 40% of delirium cases are probably preventable with the right kind of proactive, comprehensive care. And this has been studied in clinical trials, special hospital protocols, basically, that are designed for older adults and designed to reduce those triggers, result in less delirium. And these usually come in one of two forms. So one format is what was originally called an acute care for elders unit. So this is a special hospital ward that is designed to minimize hospital stressors on older adults. And so usually the beds are all together in a certain space, and there's a special multidisciplinary team caring for older adults who are in that unit. It may include a geriatrician, often a pharmacist with special expertise in identifying medications that could be problematic, physical therapy, and other resources there. So that would be an acute care for elders unit. The other type of protocol would be just a hospital delirium prevention program. So in this case, they don't have a dedicated ward or space in the hospital, but usually instead there's a protocol that can be delivered by a geriatric consultant or sometimes by a small team for patients who have been identified as at high risk, and the protocol kind of follows the patient throughout. Some hospitals even have like a special team that helps older adults who have been admitted for hip fracture, because we know that they're having surgery. Many of them, are often older, frailer, and at risk for delirium. So how does this method of preventing hospital delirium work? So usually these programs include several characteristics or factors that are, again, meant to minimize the stress of hospitalization. So first of all, they usually make a concerted effort to minimize nighttime disruptions to the older person and to ensure access to natural light during the daytime. And the idea is to reduce sleep deprivation and reduce the disruption to the sleep-wake cycle. They may have special orientation protocols, calendars or clocks in the room. The staff may make an effort to remind the person where they are, what is happening. It's also been shown that early mobilization helps. So the sooner we can get the older person sitting up, standing up with assistance, moving around a little bit, that seems to reduce the risk of delirium. Whereas if we leave them sort of lying there, immobile, that seems associated with potentially higher risks of delirium. And again, we do want to avoid physical restraints, because to feel yourself tied down and not be able to move creates a stress for people that can potentially tip them into delirium. Also very important in these programs is monitoring and avoiding use of cognitively risky medications. So not giving a lot of those sedatives and sedating medications that some hospital providers are used to prescribing fairly quickly if the older person is having some difficulty sleeping. We want to ensure that if the person needs glasses or hearing aids, they can access them, because again, being disoriented, not hearing what's going on or seeing what's going on very well can tip people into delirium. And then we want to make sure we're managing pain and also constipation as well. Another thing that is really, really helpful is for family and friends to visit. That is because we're really trying to sort of create an environment in which the body and nervous system and mind are less stressed out. So often a familiar face, right? First of all, the presence, attentive presence of a caring human is felt by people and is soothing to them. And it's even more so when it is somebody that they recognize, that they like, who is familiar, who is caring. It also provides a certain social and cognitive stimulation as well. Now, you may be thinking, well, isn't there a medication that can be given to prevent delirium? And unfortunately not. A few different medications have been tried for prevention of delirium, and none of them have been shown to help. Let me now talk about how delirium is diagnosed, right? So ideally, we prevent it by ideally every older person in the hospital, would be getting this kind of program. But often, either they're not, or not all cases of delirium are preventable. Sometimes people come into the hospital, they already have delirium, or sometimes they're just so sick that they do develop delirium. So how do we diagnose it? So again, it's a good idea to check when the older person is first admitted, because a fair number of older people come in already delirious from the illness that is causing hospitalization. And then we want to be attentive and mindful because it can easily develop during hospitalization. And if it develops, we want to detect it because then we want to take steps to manage it. And I'm going to talk about how we manage it in a moment. And then in terms of diagnosis, I would say there's the informal method and the formal method. The informal method is for the healthcare providers, the doctors and nurses to be paying attention and to be asking themselves, is this person more confused or spaced out than their baseline? First of all, are they seeming confused and spaced out in general? And if they are, is this the way they usually are, or is this a change from usual? Ideally, they would default to assuming it's a change from usual until somebody comes and says, no. This older person actually is chronically confused. But often I feel like it tends to go the other way, unfortunately. The other question that we want to be asking is, did this come on recently or suddenly? Because again, if somebody has had confusion for months and months, that is not delirium. That is something else going on cognitively. Delirium is supposed to come on within, hours to maybe a day. Now, it can wax and wane once it's there. So if the answer to these two questions is yes, there's a high probability that we are dealing with delirium here. But again, hospital staff are not necessarily asking themselves this question, and it's important to know that it is fairly easy for them to assume that a confused older adult is just kind of their usual confused stuff, even though they really shouldn't be doing that. So if somebody you care about is in the hospital and has become confused or is more spaced out than usual, it's really important that you make sure hospital staff know this is not what they are usually like. They were not like this before they came to the hospital, or this started like 1 or 2 days before they got sick. It's just really important to share that information with them because you will often be the best source of what the person is like. Then there is the formal gold standard method, which was developed by Dr. Inoue, again, Dr. Sharon Inoue, and that is called the confusion assessment method. And in this method, a clinician checks for 4 factors. First of all, are the symptoms acute in onset, meaning they came on recently, within hours to days? And is there a fluctuating course? So it kind of waxes and wanes how severe the symptoms are. Is there inattention? Is the person having difficulty paying attention or focusing or tuning in to people? Is there disorganized thinking? So that might be confusion, poor memory, hallucinations, delusions, word salad, saying things that don't make sense. And then is there an altered level of consciousness? Is the person, like really much sleepier than usual or not very alert? Or maybe really hypervigilant and amped up. And then for the diagnosis of delirium, you need to have both 1 and 2, and then either 3 or 4. And now, just to share a brief personal story about delirium diagnosis, my first case of delirium, actually personally, years ago when I was a third-year medical student, was my father, who had recently gotten chemotherapy, and then my mother called me to say, your father called me and he's not making any sense at all. And I thought, oh my gosh, that could be delirium. He was 61. And he had actually gone to one emergency room where he wasn't making a ton of sense, but they just let him leave. And so I told my mother, you have to call the cancer doctors. And when they heard this, they said, oh, that's actually very serious. He has to come in. And so he went in and he actually had a quite serious infection. So yes, somebody who suddenly stops making sense, we need to assume that it is delirium and there could be something medically really wrong. Let's now talk about how delirium should be treated. So basically, we want to use a three-part approach when it comes to hospital delirium. First, we want to identify and reverse as many of those precipitating triggers as possible. We also want to provide supportive restorative care. And then we want to monitor and do what we can to prevent injury and manage difficult behaviors. So let me now talk about these three steps in more detail. So first of all, identifying hospital delirium triggers. So first we want to check for medical triggers. Is there a new infection, such as a UTI? Is the person receiving psychoactive medications, such as diphenhydramine? So again, that's like Benadryl for insomnia, or even a benzodiazepine, actually, right? Like Ativan for insomnia is also associated with hospital delirium and probably should be avoided. Have we checked labs? Are the person's, electrolytes and kidney function okay? Any dehydration? Could they be experiencing uncontrolled pain or constipation? Is there any chance the person might be experiencing drug or substance withdrawal, such as alcohol withdrawal? And some experts even recommend giving any older adult in the hospital with delirium thiamine. And that's because when people are chronically drinking, they can become thiamine deficient. And this is considered to be a sort of like pretty benign way to make sure they're not too low on thiamine, because that can worsen delirium and brain function. And then we want to think about what about the other stressors? Is the person experiencing sleep deprivation, restraints, lack of glasses or hearing aids? Next, there's providing supportive and restorative care. So this includes, I think, most important when it's possible, because it's not always possible, is reassuring familiar people at the bedside. Ideally providing some like nurturing touch, holding the hand. That can help a lot. And then we want to do what else we can to reduce the stressors. Can we reduce the nighttime interruptions? Can we provide access to outdoor lights? Can we help them get up and start mobilizing safely as early as possible? Can we make sure they have access to their glasses, their hearing aids? Can we keep providing reminders of what's going on? Now, when we do this, it's important to not challenge their delusions or hallucinations, right? You don't want to be trying to explain them back to reality. You just kind of want to say, and then remind them, here's what's going on. You've been sick. You're going to be okay. And then anything else you can think of that is soothing to the body and nervous system. If the person likes music, maybe a little music would be good. But again, you want to avoid arguing with any delusions or hallucinations, because that tends to stress people out. And then there's preventing injury and difficult behaviors. So this can be very, very challenging, especially when people have hyperactive delirium, the kind that's kind of making them really restless or ranting or raving, or if they're freaked out about something. This can be really, really difficult because people may pull out IVs. They may try to get out of bed unassisted. It can be a very scary and risky situation. So families sometimes wonder, well, can you tie them down? And unfortunately, restraints tend to increase agitation and increase delirium, and they are associated paradoxically with injury as people are flailing, trying to get themselves undone. So it's really recommended to avoid restraints if at all possible. And it's important to note that hospital beds usually have railings. They'll have them at the top part of the bed and also the lower part of the bed. So sometimes I've seen families try to kind of like raise all the rails. The idea is to keep the person in bed, but that's also associated with injury. Many older adults flailing around have tried to sort of hoist themselves over all the rails and then have had a worse fall. So generally, you don't want to be lifting all the rails around the bed. That's also considered a form of risky restraint. Unfortunately, there are no good medication options to treat delirium. I wish there were. If there were, I would tell you about it in a second. So first, what we want to do is treat pain if it's at all appropriate. So often it is appropriate to see, could they be having pain? If we give them some pain medicine, does that sort of help them relax, and do they seem better? Now, we have to be careful with this because also high doses of certain pain medicines can also cause confusion and potentially delirium. But we do want to be asking ourselves the question, is there an uncontrolled pain issue here? Do we want to try treating pain somewhat? And if that doesn't help, then if the person really can't be soothed or talked down or supported through non-drug methods, then sometimes it is necessary for their safety to provide medication. And the medication that is used are small doses of antipsychotic. And this is a chemical restraint. It does not reduce the length of their delirium. It's associated with falls and other problems. Antipsychotics have been studied for delirium treatment in randomized trials, and they don't improve outcomes, unfortunately, when it comes to delirium. What they do is they take somebody who's really agitated and kind of sedate them a bit so that they're not as like agitated, and maybe they'll be in bed a bit more. But it doesn't really help them recover from the delirium. And so it's important to know that. So given all this, you may be wondering, so if somebody has delirium, what happens after that? And what is the prognosis? So delirium is generally going to get better with time, especially once the underlying illness is treated, the precipitating triggers are removed, and especially if the person can be put in a sort of supportive, restorative environment to recover, that tends to help a lot. Some people get better within days. Many people can get significantly better within a few days. And for older adults, it's not uncommon for it to take weeks or actually even months to fully recover. And also, I hate to say this, but a certain number of people do not recover back to where they were before. This is especially true in people who have pre-existing Alzheimer's or another form of dementia. So often delirium is kind of, recovery requires patience and supporting people. I did have one patient years ago who became quite delirious. He was 92. He was in the hospital, going from the hospital to rehab, back and forth for 3 months. And finally, his wife, who was herself 90, said she was sick of it. And she took him out against medical advice and took him home. And she basically sat by his bedside and got people to help and took care of him. And I saw him sort of a month later, and he was quite confused. And I thought, oh my gosh, and he actually slowly got better over a whole year. But I think it was partly a testament to the fact that his wife was willing and able to really devote herself to kind of nurturing his recovery. And not everybody is able to do that for somebody who is older and has experienced delirium. So you should know that since often it takes such a long time to recover from delirium, it is quite common for people to be discharged from the hospital before they have fully recovered. So they are often sent either to rehabilitation, to a skilled nursing facility, or to their home before they're fully recovered. And this is hard for families because the person often is not able to take care of themselves if they're still recovering from delirium. And so it means that family may have to step in to provide additional support for a certain amount of time. And again, especially if a person already has Alzheimer's or another form of delirium, the hospital delirium is associated with acceleration in cognitive decline. So they do usually get better. They just often don't get to be quite as good as they were before. And then also they will decline faster in the next year than they would have otherwise, is what it seems. Delirium is also associated, unfortunately, with an increase in short-term and long-term mortality. Now, this is partly that the people who become delirious are likely to be quite sick, right? And that illness in of itself, usually has repercussions for life expectancy. So again, if you've had delirium or somebody has had it, I don't want you to panic and worry too much about this because these are often things that we can't do, a ton about, the fact that it increases the risk. But I do want you to know what to expect, which is that it can take a while for the person to fully recover and that they might need extra support during that time. So given all that, what should you do if you're concerned about delirium? So first of all, prevention should always be plan A. It is just much better to try to take steps to reduce the risk of delirium. And so especially if you or somebody you care about has experienced delirium in the past, having had past episodes of delirium does increase the chances of developing delirium, if you're put under stress. And so it becomes even more important to take preventive measures if you have experienced delirium in the past. So prevention should be plan A with prompt detection and treatment plan B. So for prevention, before hospitalization, especially if this is an elective hospitalization, like something like a joint replacement or something like that, try to pick a hospital that has a delirium prevention program that either has a special unit, acute care for elders, that will do this, or otherwise has some kind of delirium prevention program. And then if your hospital doesn't offer that, you can still talk to your health providers about ways to reduce hospital delirium. If you're looking into an elective surgery, you can talk to the surgeon about it and also anesthesiologists and let them know you're concerned about it and invite them to kind of brainstorm with you. What are things that, might be feasible to reduce your risk of delirium? So for instance, for certain kinds of procedures, it might be an option to go with spinal anesthesia instead of general anesthesia, and that is associated with a lower risk of delirium. Next, arranging for your care circle, your family, your friends, whoever is available to visit and provide, again, that human presence, caring touch, and support during the hospitalization might help as well. And then during hospitalization, again, don't assume that hospital staff will detect and diagnose delirium. It's very easy for them to miss it. Do speak up if you notice that your older relative is more confused or more quietly spaced out than usual, right? So again, if they're very quiet, maybe they're tired and resting, but if you start talking to them and they can't track what you're saying or remember what you're saying, and that's not their usual way of being, you want to bring it up to hospital staff so that they can evaluate for potential delirium. And you want to make it very clear this is not what they're usually like. You can also advocate for supportive care. Again, what I had on the list there, like, do they have their glasses and hearing aids? Can they have, a room with a window? Do they have to be woken up at night, or can we minimize that? And be careful about asking for medication to help them sleep, because that often kind of backfires. And then if you're in the situation where somebody you care about has recently had hospital delirium, remember that a supportive, reassuring, restorative environment helps a person recover. Provide reassuring presence from family and friends if possible. Be patient. Recovery can take a while. Let the health providers know if delirium symptoms return or worsen. So, to summarize, hospital delirium is really common, affects an estimated 1 in 3 older adults, with that rate going up as people get older and older. Another risk factor is to have a pre-existing dementia such as Alzheimer's. It can be easily missed by busy hospital staff. The consequences are significant. It makes hospitalization, hospital discharge, and recovery harder. It can take weeks to months to fully recover and can accelerate the pace of cognitive decline. So I believe it is worth taking steps to prevent or avoid delirium if at all possible. To prevent this, look for hospitals that have, again, those special acute care for elders units or prevention protocols. Talk to your health providers about options for reducing delirium risk. And then if you are dealing with diagnosis and treatment, make sure hospital staff are notified if there's new confusion or inattention in an older person you care about. And the treatment should involve an evaluation for both like new medical triggers and also other precipitating factors, and then providing supportive care and preventing injury as best possible with use of antipsychotics as a really last resort. The reassuring presence of familiar people does help. So if you have the bandwidth to do it, I know not everybody does. It can be very hard to be spending a lot of time in the hospital, but if you have the bandwidth, that can help. And so with that, thank you so much for watching. If you found this video podcast helpful, if you're here on YouTube, please go ahead and subscribe. It does help more people find the channel. If you've been listening to the audio version on the podcast feed, come take a look at the video if you get a chance. You'll see my key points being displayed on the screen. So thank you once again, and I look forward to seeing you all again on a future episode of the Better Health While Aging video podcast.